بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه وسلم أجمعين. سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. اللهم علمنا ما ينفعنا وانفعنا بما علمتنا يا كريم. Dear colleagues, and here is the second part of the topic concerning the hematological bone diseases. And you remember that we have already finished the issues of vascular necrosis, including all the or most of the affected areas in the body. Also, we have discussed the hemochromatosis and sickle cell disease. Now we are going, in this second part, we are going to discuss the thalassemia major, the hemophilia, hereditary spherocytosis, and the hematologic malignancies, including lymphoma, leukemia, and myeloma. Starting by thalassemia, and this is an autosomal recessive disease which is originated in the Mediterranean area. And it is well known that the adult hemoglobin is composed of hemoglobin A, which represents about 98%, and the hemoglobin A2, which represents about 2%. The thalassemia is caused by a defect in the synthesis of one or more of the hemoglobin chain. Then we have the thalassemia minor and the thalassemia major. If one mutated gene, then this is called thalassemia minor, and the symptoms are mild. If there are two mutated genes, and this is called thalassemia major or Cooley's anemia, and the symptoms of Cooley's anemia are often moderate or severe. And this is the algorithm if you have the parents with thalassemia minor. Two parents with thalassemia minor, there is 25% one of the offsprings, 25% of the offsprings will have thalassemia major, 25% will be normal, and 50% will be of the thalassemia minor. And these are the different algorithms concerning the parents. If one of them has thalassemia and the other one is healthy, and so on, then most of the hemolytic anemias, including the thalassemia, will present on imaging by the changes due to marrow hyperplasia. And marrow hyperplasia means that the bone marrow is hyperplastic, is increasing in size, and this will result radiologically in expansion of the medullary cavity of the bones, with consequent thinning of the cortical bone and resorption of the cancellous bone. The overall bone density is decreased, and there is some yellow to red bone marrow reconversion. There are very pathognomonic changes in the skull, which appear here in the famous radiological sign known as the hair on end appearance. And this appearance is due to the hyperplasia of the bone marrow with dilatation or with increase in the size of the diploic space. These changes do not affect the occipital bone because there is no hematopoietic bone marrow in the occipital on the occipital bone. And this is another example of the hair on end appearance in the skull lateral view and the frontal view. Also, you can note that there is almost total loss of the air in the paranasal sinuses because of the hyperplastic marrow will encroach on the spaces provided by the paranasal sinus. Actually, the hair on end appearance is very clear on skull radiographs and also on CT. But on MRI, you can see that the block space is markedly widened and it does not contain yellow marrow. Of course, you know that the yellow marrow contains fat, and the fat will appear bright in the T1 and less bright in the T2. But the red marrow will appear of intermediate signal in both T1 and T2, as you can see here. And this is the differential diagnosis or the causes that can result in this hair on end appearance. And you can remember them by these letters: high NEST, H for hereditary spherocytosis, I for iron deficiency anemia, N for neuroblastoma, E for enzyme deficiency like G6PD deficiency causing hemolytic anemia, S for sickle cell anemia, and T for thalassemia major. Then the rest of the changes along the skeleton and in the body due to bone marrow hyperplasia include the affection of the facial bones resulting in the rodent facies, I will show. Then hyponematization of the paranasal sinuses, which are occupied by the hyperplastic bone marrow. The ethmoidal air cells are usually spared due to the lack of red bone marrow in this particular location, and there are some deformities and malocclusion of the teeth. In the ribs, you have this phenomena which appears in the X-ray and is known as the rib within a rib appearance, and it is also due to bone marrow hyperplasia. In the extremities, you got widening and expansion of the metacarpals and the metatarsals. You got premature fusion of the epiphysis, osteoporosis, and the signs of extramedullary hematopoiesis. In the GI, you may have gallstones, hemosiderosis in the liver, and splenomegaly. And here you see a patient with thalassemia major, and there are evidences of extensive bone marrow hyperplasia with expansion of the zygoma and the maxilla, markedly encroaching on the air spaces within the maxillary sinuses. And this will result in abnormal protrusion of the affected sinuses and giving this classic appearance, which is known as rodent facies. Then in the mandible, you may get shortening or loss of the roots of the teeth, and you may get expansion of the bone marrow spaces due to bone marrow hyperplasia, widening of the diploic spaces, enlarged bone marrow spaces in all bones all over the body, including in the mandible, osteoporosis I have mentioned, enlargement of the jaw due to the bone marrow hyperplasia, of course, reduced size of the maxillary sinuses, the air in the maxillary sinuses, shortened tooth roots, as you can see here, and thinning of the bone cortex due to expansion of the bone marrow. And this is what we call the rib within a rib sign. If you look carefully here, and you can see that what looks like a rib inside another rib, and the cause of this, of course, is due to the bone marrow hyperplasia with expansion of the diploic spaces within the ribs. And here you can see the significant or the evident diffuse decrease bone density with resorption of some of the trabecular bone and the coarsening of the primary trabeculae. Then here you can see that there are expansion of the ribs also, giving the appearance of a rib within a rib sign. And here you see that the diploic space within the ribs is markedly expanded. There are vertical striations, especially noted in the posterior aspects of the ribs, and this may be associated with soft tissue masses along the affected ribs, which is known as the extramedullary hematopoiesis. And this is also an example of thalassemia major, where the spleen has been removed. The density of the liver is significantly elevated due to the iron deposition in the liver. There is bone marrow hyperplasia with expansion of the ribs, and there are multiple extraosseous soft tissue components representing the extramedullary hematopoiesis. And this is the same sign of expansion of the bone marrow with a rib in a rib sign. Then we came to the hereditary spherocytosis, and this is a group of hemolytic anemia. And you remember that in any type of hemolytic anemia, you got the appearances of bone marrow hyperplasia. Then how can you know that this is thalassemia or hemolytic anemia or hereditary spherocytosis or sickle cell anemia, for example? And this is reached, of course, through the laboratory analysis of the blood. Then about 70% are inherited as autosomal dominant and 15% as autosomal recessive, and 15% are sporadic cases. The patient will present by anemia, jaundice, splenomegaly, and there is usually positive family history, especially for the inherited cases. And what are the causes of spherocytosis? Intravascular or extravascular destruction of the RBCs, and this will result in this the hemolytic anemia is caused by intravascular or extravascular destruction of the RBCs, and the patients present by anemia and jaundice. These are the causes of hemolytic anemia. Metabolic defects like glucose G6PD, glucose 6-phosphate dehydrogenase deficiency, pyrophosphate kinase deficiency, red blood cell membrane hereditary abnormalities in the red blood cell membrane production, like in hereditary spherocytosis, abnormalities in hemoglobin production, like in thalassemia, sickle cell anemia, and congenital dyserythropoietic anemia. Some of the acquired causes, like autoimmune diseases, systemic lupus erythematosus, rheumatoid arthritis, infections like viral infection or mycoplasma or lymphoproliferative disorders, portal hypertension leading to hypersplenism, paroxysmal nocturnal hemoglobinuria, drug induced زي فينستين أو كوانيدين أو ألفا ميثايل دوبا, lead poisoning, malignancies, and prosthetic heart valve, artificial valves due to mechanical trauma to the RBCs. The hemolytic anemia, whatever the cause, will result in two main radiological appearances. The first one is bone marrow hyperplasia, and the second one is extramedullary hematopoiesis. The pathogenesis of this disorder is actually unknown, and here you can see some of the causes of extramedullary hematopoiesis. In leukemia, in polycythemia vera, in essential thrombocytosis, in myelofibrosis and myeloid metaplasia, in Hodgkin disease, in hemoglobinopathies like sickle cell disease, thalassemia, and hereditary spherocytosis. All these lesions may present by or one of the imaging finding in these cases is the extramedullary hematopoiesis. Then extramedullary hematopoiesis can involve abdominal organs, especially the liver, the spleen, and the lymph nodes, and this will result in enlargement as well as increased density of both the liver and the spleen. The lesions are hypermetabolic if you perform the PET-CT scan. Extramedullary hematopoiesis less commonly affects the pleura, the lung, the gastrointestinal tract, the breast, the skin, brain, kidneys, and adrenal glands. But these are the common areas to be affected beside the skeleton. The paraspinal masses are either unilateral or bilateral with a characteristic lobulated margin. This is a chest X-ray of patient with beta thalassemia, chest pain and dyspnea, and you got paramediastinal lobulated soft tissue masses that are projected posteriorly in the lateral view. And in the CT scan, you see the characteristic features of bone marrow hyperplasia with expansion of the rib and the coarse trabeculation of the medullary cavity. Then you got the characteristic appearance of extramedullary hematopoiesis in the form of soft tissue masses with speculated internal septation related to the areas of bone marrow hyperplasia. If you have an MRI, which and this time you got some difficulties in the diagnosis, but if you look carefully, you can see that the posterior aspect of the ribs on both sides are markedly expanded, and they are associated by extraosseous soft tissue components. Of course, the best way to diagnose extramedullary hematopoiesis is the CT scan. Then we came to hemophilic arthropathy, and we have mentioned this type of bone disease in many times before in the lecture of polyarthropathies and also in the lecture of bone and joint infection. But I have also included this topic here because of its intimate relation to the subject we are discussing. Then hemophilic arthropathy, we have two types of hemophilia. Hemophilia A and B, which are sex-linked, and they are seen only in males, and they are associated with bony changes. While hemophilia C is not sex-linked, it can be seen in males and females, and the bones are rarely affected. And hemophilia may affect a single joint or may affect multiple joints, particularly the large joints, especially the knee. And there may be a joint effusion, which may show fluid level due to the presence of the bleeding inside the joint. Chronic hemarthrosis and hyperemia will lead to gross disturbances in the form of epiphyseal enlargement, widening of the intercondylar notch, and sometimes premature fusion of the epiphysis. Then it may be chronic periarticular erosions and subchondral cysts. If you look here for a lateral view of the knee of a patient with hemophilic arthropathy, and you got a very big soft tissue swelling around the knee, which is just a blood inside the knee joint, hemarthrosis. And you can easily appreciate the density of the blood compared to the density of the muscles, for example. Then 50% of patients with hemophilia will develop a severe form of arthropathy. And I have mentioned that hemophilia is an X-linked recessive disease affecting males, and it is usual for a joint to be repeatedly involved by by, of course, bleeding and the consequences of bleeding. And chronic proliferative synovitis will in the development of hemophilic arthropathy. The hemophilic arthropathy is in the form of blood inside the joint and erosive changes of the articular cartilage with destruction of the articular surfaces ending by secondary osteoarthritic changes. The synovial hyperplasia, the chronic inflammation, the fibrosis, and hemosiderosis are the causative factors for the significant joint damage. Synovial masses will erode the cartilage and the subchondral bone. The most common joints to be affected are, of course, the knee, the elbow joint, the ankle, the hip, and the shoulder. MRI is considered a good imaging modality for diagnosis because it can show the blood or the hemosiderin inside the joint, and can also show the changes in the bone marrow and in the articular cartilage. You know that the chronic blood or the hemosiderin will appear black in the T1 and black in the T2 weighted image. Then if you look for a joint that is affected by hemophilia, and you can see that there are diffuse synovial thickening and the deposition of hemosiderin along the synovial reflections, which will appear of low signal in all pulse sequences. The second synovium will show low signal due to hemosiderin. If you inject contrast, actually you will not see significant enhancement. And this is one of the differentiating points between pigmented velonodular synovitis, which will show low signal in the T2 weighted image, and if you inject contrast material, the synovitis, pigmented velonodular synovitis will enhance. but the hemosiderin deposited in the joint in a patient with hemophilia will not enhance. And also you can consider other radiological manifestations of hemophilia and the clinical picture as well. Then you may got joint effusion, cartilage loss and destruction, and the early replacement of these factors may prevent the destructive changes in the joint. Then increased density of the periarticular soft tissue due to bleeding, distension of the joint by blood rather than due to effusion. Diffuse decreased bone density is of course due to limitation of the joint movement. Chronic synovitis will develop, and this will lead to destruction of the articular cartilage and consequently you got narrowing of the joint space. Then widening of the intercondylar notch in the knee is considered one of the pathognomonic signs of hemophilia. And this widening is due to the presence of intercondylar hemorrhage. Intercondylar hemorrhage will lead to widening of the intercondylar notch. Intraosseous hemorrhage will lead to osteolytic lesions. Subperiosteal hemorrhage may cause periosteal reaction. Epiphyseal hemorrhage may cause a slippage of the epiphysis, premature fusion, and deformities. And this is an example of an advanced case of a hemophilic arthropathy with secondary osteoarthritic changes. Then one may say, how can I diagnose this as hemophilic arthropathy? Why? I should not say that this is the regular form of osteoarthritis. Then number one, and I hope this will be the attitude of any radiologist in the clinical practice and in the exams. Number one is the clinical picture. Number two is the age of the patient. Number three is the other manifestations in the body to support one of these diagnoses. Number four is the bilaterality. And you know that osteoarthritis, whenever it is severe like this, if it is of the primary type, it will affect both sides. But if one of the knee joints is absolutely normal and the opposite knee joint looks like this, then you know that this is secondary osteoarthritis, not a primary type. Then you look what is the underlying cause for this secondary osteoarthritis. And many times in the exam, they want you to have a look, especially in the knee, of course, for the intercondylar notch, if it is wide, and you may consider this as one of the findings of hemophilia, and then you correlate with the rest of the imaging findings, and you may reach the diagnosis of hemophilic arthropathy. This patient is 30 years old, and whenever I said the age, I consider that hemophilia, of course, occur at a much younger age than secondary than the primary degenerative osteoarthritic changes. In this patient with severe hemophilia has affection of the elbow, affection of the knee, and affection of the ankle joint. The changes are much more severe in the elbow and in the knee joint. And on MRI, as I have mentioned before, you may got multiple low signal, extremely low signal lesions within or along the periphery of the joint. And these lesions are black in the T1 and black in the T2, and they will not enhance if you inject contrast material in most of the cases. Then the clinical picture of a patient with known hemophilia, then you consider these appearances diagnostic of hemophilic arthropathy. Hemophilic pseudotumor is a rare complication of hemophilia which develops when there is a bleeding inside the bone or the muscle. The incidence is about 2% in hemophilic patients, and it is common in the lower limbs and the pelvis. But in this example, you see a hemophilic pseudotumor in the forearm, for example. It can occur anywhere in the body, but the most two common sites are the pelvis and the lower limb. This lesion is a well-defined unilocular or multilocular with internal septations. It is an osteolytic expanding lesion, usually of a very big size, but this lesion may involve the epiphysis, the metaphysis, or the diaphysis. It is associated with endosteal scalloping, perilesional bone sclerosis, cortical thinning or thickening, thinning of the outer margin, thickening of the inner margin, trabeculation and septations, and maybe pathological fracture. In the MRI, this hypointense rim due to fibrous tissue and hemosiderin is considered one of the pathognomonic features of hemophilic pseudotumor in both T1 and T2 weighted images. And this is a very big hemophilic pseudotumor in the forearm of a patient known to have hemophilia. Then you got a very big lesion that is expanding with a soft tissue component that is unilocular, marked thinning of the bone margins. And this is another example of a hemophilic pseudotumor in the iliac bone. And this is associated with osteolytic lesion in the posterior aspect of the iliac bone, as well as a big extraosseous soft tissue component. It's not clearly seen in the straight radiographs, but you can see the lesion in the CT scan. Then if you look to the MRI, as I have mentioned before, and this is one of the pathognomonic features of hemophilic pseudotumor is the presence of low signal rim surrounding the extraosseous soft tissue component in both T1 and T2 due to fibrosis and hemosiderin deposition. Then we came to the hematological malignancies, and we have three: leukemia, lymphoma, and myeloma. Leukemia is one of the well-known hematological neoplasms, and it results from the overproduction of immature or abnormally differentiated cells in the bone marrow. The cells are often, but not always, extend into the peripheral blood, meaning that the immature or abnormally differentiated cells are present in the axial skeleton, and it may go to the peripheral blood often but not frequent. Since the need for the diagnosis to have a central bone marrow, like in the sternum, for example, in order to reach the accurate diagnosis. Leukemia is divided according to the percentage of immature or blast cells in the bone marrow or in the peripheral marrow. In the acute condition, the immature cells exceed 20% of the bone marrow population, and the symptoms are early seen in the patient. In chronic cases, there is proliferation of mature cells, but they are abnormal. And these are the leukocytes, resulting in leukocytosis with or without associated cytopenia. And this is the schematic representation of the bone marrow cells. We have the stem cell or the blood stem cell, which is the precursor of the lymphoid stem cell, which will result in the production of lymphocytes, including the B lymphocyte and the T lymphocytes. Then we have the myeloid stem cells, which will produce the RBCs, the platelets, and the red cells. The red cells are this is the myeloblast or the myeloid blast cells, which are the precursor of eosinophils, neutrophils, basophils, and monocytes. Then we have lymphocytic leukemia and we have myeloid leukemia. This will affect the lymphocytes and the precursors of lymphocytes, and this will affect uh, uh, the white cells. And this just to remember that acute myeloid leukemia is common in old age, and acute lymphoblastic leukemia is common in children, and both interferes with the development and the function of the healthy cells, including the rest of the white cells, the red blood cells, and the platelets. Then, lymphocytic leukemia is the disorder of the lymphoblastic cells. Then this lymphocytic leukemia develops in lymphocytes in the bone marrow and is commonly affecting the children. In about 80% of the cases are severely symptomatic. Chronic lymphocytic leukemia is commonly seen in elderly patients. Myeloid leukemia affects the white cells other than lymphocytes, RBCs, and the platelets. All these are not included under this title. Acute myeloid leukemia is seen in adults, but it is considered the second most common in children after lymphocytic leukemia. Then chronic myeloid leukemia is also seen in adults, where the Philadelphia chromosome is present in about 90% of the cases. Then to remember once again, lymphocytic leukemia is a disease of the pediatric age group, the acute type. The chronic type is the disease of elderly. Myeloid leukemia is the disease of adults, both in the acute form and in the chronic form. But acute myeloid leukemia follow the lymphocytic leukemia in the incidence after the lymphoblastic leukemia. Then if you look to the normal blood cells, and here you can see that most of the cells are RBCs, some of the platelets, and some types of the white cells. But in cases of leukemia, and here you can see that the most of the field is occupied by abnormal white cells, and there is a significant reduction in the number of the RBCs as well as the platelets. Then we should consider that most of the radiological findings in leukemia are not pathognomonic. Even more, In patients with leukemia, the plain films may appear totally normal. Then, one may say, how can I reach the diagnosis? The diagnosis is already settled after blood analysis and external puncture. Then, what is the role of imaging? The role of imaging is to look for other manifestations of the disease that I will mention and to look for the complications. Then, in most of the cases, we do not diagnose leukemia from the radiographs. But if you know beforehand that this patient is known to have leukemia, then you may say that these changes can fit for the diagnosis of leukemia. What are the changes? Osteopenia is the most frequent finding, and this osteopenia can be due to decreased bone density senile, can be due to myeloma, can be due to any other pathology which can lead to decreased bone density. Then radiolucent metaphyseal bands or alternating radiolucent and radiodense metaphyseal lines, especially in treated cases. You may got some osteosclerotic appearance, and you may got also collapse of one or more of the vertebral bodies, which is known as the vertebra plana. Then, what is the differential or the causes of the vertebra plana? It is not just leukemia which can cause this, but there are a lot of cases, and you can remember by this abbreviation: FETISH, fracture, xenophilic granuloma, tumor like metastasis, myeloma, and the leukemia, infection, steroids due to avascular necrosis, we have mentioned this, and hemangioma. Then these are the manifestations of leukemia by MRI. I repeat, they are not pathognomonic. There may be bone marrow lesions, multiple osteolytic lesions, or areas of bone marrow abnormal signal, low signal in the T1 and high signal in the T2. And if you inject contrast material, they will enhance with contrast. Then the lesions may appear osteolytic on the X-rays and the CT scan. Then some soft tissue deposits forming mass-like lesions within the muscles may be also seen. The lesions are iso-intense to the muscle on T1 with increased signal on T2 and post-contrast enhancement. Leukemia cutis represents focal deposits of leukemic infiltrates in the epidermis, the dermis, or the subcutaneous tissues. Then, if you do not know anything about this patient and you are confronted by this X-ray of the leg, what do you see? I see diffuse, permeative, osteolytic involvement of most of the tibial shaft. There is some metaphyseal bands of translucency, minor perosteal reaction, and these changes are to a much lesser extent seen in the distal part of the fibula. Then what do you think about this diagnosis? There are a lot of differential diagnoses, including sickle cell anemia, including osteomyelitis, including leukemia, including any other possibility. But how can you diagnose this as leukemia? The patient is already diagnosed to have leukemia by blood analysis. And if you look carefully for this X-ray, you see nothing. But if you look to the MRI, and you can see multiple bone marrow infiltrative lesions that are of low signal in the T1 and high signal in the T2 weighted image. How can you know that these are due to leukemia? It's from the blood picture of the patient. And this patient is known to have leukemia, presented by severe pain in the knee. Then the diagnosis is already clear, and you see a bone marrow infiltrative lesion that is of low signal in the T1 and high signal in the T2 without cortical disruption, perosteal reaction, or extraosseous soft tissue component. Then, in this particular history, you diagnose leukemia. If this history is not present, and the age of the patient is 45, then you consider lymphoma, which is one that can give this appearance. You consider metastasis that can also show similar appearance. Then it's very important for us, especially in hematologic bone diseases and also in the endocrinal bone diseases, to have a detailed history and, if possible, the lab findings to help us reaching the diagnosis. And as I have mentioned before, if you have the PET scan, it will show metabolically active lesions. And in this particular domain, I say that this PET scan is not helpful in the diagnosis, but it's helpful in the follow-up of treatment. Then sometimes, but it's not a frequent finding, to see infiltration of the spinal cord. This cord is markedly expanded. It is of relative increased signal in the T2 weighted image. And if you inject the contrast material, you may see very faint enhancement. If you know that this patient had leukemia, then this is leukemic infiltration. If you know that this patient had lymphoma, then this is lymphoma infiltration. If you know that this patient had a primary malignancy, although this is not a frequent appearance of metastasis, then you should look carefully for the possibility of metastasis. Then, if you look here, and you can see that there is significant decrease in the bone marrow signal in the T1 weighted image, with almost return to normal signal in the T2 weighted image. If you see this, don't rush for the diagnosis of bone marrow infiltration like leukemia or myelofibrosis or lymphoma or so. But there are a lot of differential diagnoses for this particular appearance. And actually, we describe what we can see, and we drive the attention of the clinician to assess the blood for the possibility of hematologic disease. Then, in this patient, you can see bilateral, almost symmetrical, metaphyseal translucencies or osteolysis in the distal part of the femur and the proximal part of the tibia. This is what I have said before. All the acute lymphatic leukemia with musculoskeletal manifestations may simulate rheumatoid arthritis, osteomyelitis, septic arthritis, transient synovitis. Patients with musculoskeletal pain may or may not have radiological abnormalities, and the musculoskeletal manifestations of leukemia are not pathognomonic. then the hematologic abnormalities can be subtle or even absent. And this is a patient with acute lymphoblastic leukemia, and he got multiple bone marrow infiltrative lesions in the femora, in the tibial shafts, and also at multiple vertebral levels. Then we came to the multiple myeloma. And multiple myeloma is considered the most common primary malignant bone tumor in adults. And the myeloma is considered, according to the literature, an incurable disease. We have 4 patterns of myeloma in the skeleton. Number 1, disseminated form in the form of multiple well-defined punched out lytic lesions. Diffuse skeletal decreased bone density, solitary plasmacytoma, like this one, a single expansile destructive lesion, usually seen in the vertebrae but can also be seen in the long bones. Then the sclerosing type of myeloma, which is considered a rare manifestation because myeloma is mostly an osteolytic disease. Combined multiple myeloma and osteosarcoma account for these 2 main tumors, represent about 50% of all primary bone malignancies. This osteosarcoma, of course, you know that is the most common primary malignancy in the young age. Then here you can see different manifestations of myeloma. This is the normal appearance of the bone marrow in the T1 weighted image. And this is multiple lesions which are not discriminable from metastasis, for example. And this is the diffuse type where you got significant decrease in the bone marrow signal in the T1 weighted image compared to the normal appearance. Then patients with myeloma may present by pain, anemia, renal failure, proteinuria, and hypercalcemia. The complications of multiple myeloma include pathological fractures, amyloidosis, recurrent infection due to leukopenia, and the plasmacytoma may develop into multiple myeloma. And the laboratory findings, you can got reverse of the albumin globulin ratio, and these are the normal figures in the normal candidate. Then you may got monoclonal gammopathy like IgA and or IgG peak. Benzones proteins in urine, hypercalcemia, and decrease or normal alkaline phosphatase level unless there are fractures. And about 1% of the cases have negative serum electrophoresis and the negative urine for Benzones protein. Multiple myeloma represents 1% of all malignant disease, 10% of hematologic malignancies, and the clinical appearances I have mentioned, and also I have mentioned the laboratory findings. Then one of the most common and also the most easy radiological finding for diagnosis of multiple myeloma is that what you are looking for, where you got multiple osteolytic lesions in the calcareal bones, and these lesions are of almost similar size. They are sharply defined with punched out edges. And they simulate the raindrop as you can see here. Then 75% of patients with myeloma may have positive X-ray finding in the form of solitary osteolytic lesion, which is known as the plasmacytoma, multiple osteolytic lesions of uniform size, diffuse decreased bone density without detectable lesions, vertebral fracture or collapse, and the sclerosing lesions, which is the rarest to be seen in the clinical practice. CT is one of the sensitive modalities. It will show extensive osteolytic lesions with variable degrees of vertebral fractures and collapse. If you have the bone scan, according to the literature and the primitive knowledge we have taught previously, that multiple myeloma usually show negative activity on bone scan. An MRI, you got multiple lesions of low signal in the T1 and high signal in the T2 weighted image. If you inject contrast material, they will enhance. And one of the suggestive uh, finding on MRI imaging of myeloma is to see that the affected vertebra is partially collapsed and its posterior edge is convex, encroaching on the spinal canal, and this actually is not seen with metastasis. In metastasis, if you look to this vertebra with straight posterior margin, this is common finding for metastasis. But this, if you see this appearance, is not pathognomonic, but it is suggestive of myeloma. And this is the appearance of myeloma by plain film. Of course, the detection of myeloma by plain film is one of the difficult tasks in radiology, but the CT scan is helpful in this particular domain, especially if you are looking for myelomatous lesions in the ribs. And this is an example of multiple myeloma describing osteolytic lesions at multiple vertebral levels, affecting the neural elements as well, with some loss of the vertebral height. And this is the metastatic deposits. Deposits are usually of variable size, are usually of mixed type. There may be osteolytic and osteolytic lesions, and deposits may be associated with extraosseous soft tissue component. All these can differentiate myeloma from deposits, including, of course, the presence of a primary malignancy in cases of metastasis. Finally, we came to the third hematologic neoplasm, which is the lymphoma. And we have two types of lymphoma, the primary bone lymphoma and the secondary lymphoma. Lymphoma accounts for less than 5% of bone tumors and less than 1% of non-Hodgkin lymphoma is the primary bone lymphoma. The primary bone lymphoma can affect any age group, while the peak of age incidence is 55%. It is rare in children below the age of 10 years. The symptoms are not specific, but they include pain, swelling, pathologic fractures, and the cord compression if the lesion affects the vertebrae. The most common appearance in imaging is the lytic destructive lesions, but you know that there may be some sclerotic texture of the affected bones of lymphoma, and this may help to spot the diagnosis. And also, you remember that we have many times discussed the differential diagnosis of a solitary dense vertebra, and we have said that these include metastasis, lymphoma, and Paget disease. Then you remember that one of the possibilities of a sclerotic vertebra, or what's known as ivory vertebra, is the lymphoma. The majority of the lesions are osteolytic, but blastic or osteosclerotic lesions are also common. And osseous involvement may occur by blood spread or by lymphatic spread or from direct extension from the adjacent affected lymph nodes. The most common sites to be affected by lymphoma are the spine, the pelvis, the ribs, the femur, and the sternum. Then these are the appearance in the spine, erosion of the anterior aspect of the vertebra due to impression or affection of the bone by the adjacent affected lymph nodes. Then the nodular sclerosing Hodgkin lymphoma is diffuse increased density with or without erosion. Ivory vertebra is a single or solitary dense vertebra. The intervertebral discs are, of course, not affected. And here you can see multiple sclerotic lesions in this sagittal reformatted CT scan of the dorsolumbar spine. And these vertebrae, the differential diagnosis may include lymphoma and metastasis. And because of the clinical data of Hodgkin disease, then you know that this is lymphoma. This patient, the lymphoma of the femoral head and the neck, associated with what looks like an extraosseous and soft tissue component. The secondary bone lymphoma is, of course, much more common than the primary lymphoma, occurring in about 15% of disseminated lymphoma. Then the clinical findings, the mean age group is also about around 55. Dull aching pain and fatigue, fever, night sweats, and weight loss, pathological fractures, neurological symptoms due to spinal cord or nerve root compression. These are the frequencies of affection of different bones, the femur, the pelvis, the humerus, the tibia, and this is the frequency of the appearance on the imaging. Osteolytic lesions most common, mixed lytic and the blastic lesion, and osteoblastic lesions are the rarest. Then here you see that there is diffuse sclerosis of the proximal part of the tibia was loss of the corticomedullary differentiation. You cannot see the cortex, you cannot differentiate the cortex and in the medulla. Then in a patient like this one, if you see that the epiphysis is not yet fused, the best diagnosis will be Ewing sarcoma. But after epiphyseal closure, still Ewing sarcoma is one of the differentiating points, but comes here also the bone lymphoma. Then non-Hodgkin lymphoma is 4 to 5 times common as Hodgkin disease of the bone. 3 to 7% of all primary osseous malignancies, and most frequently affects the spine, the skull, and the pelvis. And here the radiological manifestations, which include cortical destruction with extraosseous soft tissue component. Sometimes you got bone sequestra, which you remember are seen in the chronic osteomyelitis and sometimes in eosinophilic granuloma, fibrosarcoma, and malignant fibrous histiocytoma. Preosteal reaction is seen in about 50% of the cases. Extraosseous soft tissue masses are seen well by MRI. Pathological fractures may be seen in around 20% of the patient, and vertebral compression or vertebra plana lymphoma is one of the contributing factors. PET scan is more sensitive than gallium scan, and PET scan is also rapid in the performance compared to the gallium scan, and the lymphoma lesions are metabolically active. What's important is that PET scan is not tumor specific, since it can show a metabolic activity in inflammatory lesions in hyperplastic bone marrow disease. And one important factor also is that, according to the literature, the PET scan should not be performed until 2 to 3 months after radiotherapy and 1 month following chemotherapy. Used PET scan is used during and at the end of therapy for more accurate assessment of the treatment response. And here you can see a patient with multiple lesions in the vertebrae associated with subtotal collapse of L5, and the lesions are of low signal in the T1 and intermediate signal in the T2. This can fit for metastasis and also can fit for myeloma. And this patient is known to have non-Hodgkin lymphoma and is receiving chemotherapy. Then you diagnose these as multiple as lymphoma. And here you can see a big mass anterior to the vertebra, anterior to the spine, with erosive changes in the anterior aspect of L3 and the infiltration of most of L4 vertebra by lymphoma. And this is another example, and you see a bone marrow infiltrative lesion associated with extraosseous soft tissue component. And one may say, why I don't consider this as, let's say, metastasis? Good. Um, uh, One of the sarcomas, okay, but you should consider the age of the patient, and you may put the most reasonable differential diagnosis. And you remember that lymphoma and metastasis are usually taken into consideration in such conditions. Then here is a patient with an sclerotic lesion in the tibia, and she is a female, 20 years old, with leg pain. Then you got sclerotic lesion, and the MRI showed extensive bone marrow infiltrative pathology with extraosseous soft tissue component. Then the diagnosis, as I have mentioned before, should include Ewing sarcoma and may also include osteosarcoma, leukemia, lymphoma, and metastases, as well as chronic osteomyelitis. And this is an example of primary bone lymphoma showing a faintly osteolytic lesion in the X-ray and can be easily overlooked. But in MRI, you see this bone marrow infiltrative pathology, which is of low signal with a necrotic center. Actually, this is not pathognomonic for lymphoma, and it includes a lot of differential diagnoses. But if you know that the patient has lymphoma, this will facilitate the diagnosis. Finally, we have a few words about the muscle lymphoma, which is rare, representing about less than 2% of all lymphomas. And it is usually of the non-Hodgkin type, and the age of presentation is around 70 years. The muscle, any muscle can be involved, but commonly seen in the thigh, in the trunk, and in the upper and lower limbs. Metastatic spread from nodal disease or osseous disease are common than the primary muscle lymphoma. And the muscle lymphoma should be differentiated from metastasis, from rhabdomyosarcoma, from extraosseous, extraskeletal Ewing sarcoma, and infectious biomyositis together with a lot of soft tissue malignant lesions. And this is an example of a patient 70 years old presenting by a thigh mass over 2 months period of time. The lesion is of low signal in the T1, and it is of the high signal in the stair with appreciable contrast enhancement. The patient had a previous history of non-Hodgkin lymphoma of the breast 26 years ago. Then this history will help you to put the possibility of lymphoma for this muscle mass. But if not, if you don't have such a history, then you consider this one of the sarcomas in the thigh, including the leiomyosarcoma, the rhabdomyosarcoma, the non-differentiated type of liposarcoma, the lymphoma metastasis, and a lot of differential diagnoses in such a lesion, and you need the help of biopsy to reach the final diagnosis. Thank you very much. Alhamdulillah.